Hi guys. So in this session, we're going to be looking at why treatment sometimes fails. I think it's an important aspect that we should consider because it can help us really comprehend how to avoid failing our patients and how to do the best by them. And it's always a good learning experience when we see people who haven't got better if we can truly reflect on what's happened during their story in terms of where we took them from day one when we first met them and where we've ended up and how we've come to get to that stage. So I think it's a really critical component of any physiotherapy, but particularly when it comes to managing tendons, because this sort of length of time can sometimes be quite lengthy. Now, the key factors fall into a whole variety of components that we need to consider to avoid failing our patients. But the biggest one that I see time and time again is a failure to actually really pin down with the patient what they think's happened, what they think's been undergoing during their problem with their tendon, and what that means to them. Because often if they've not been able to do their sort of typical sport, let's say like running for somebody with an Achilles problem, they've lost a sense of self. And that can lead to a whole variety of varied psychosocial sort of changes in their processing of the environment and what's happening to them, particularly around sort of avoidant behaviour. They'll often sort of try things, find it flares them up, and then totally avoid it instead of actually just looking at a much smaller amount of that activity in a graded re-exposure. And this fear can really sort of put a sort of damper on any ability that we may have of getting that patient to improve their situation. Equally, catastrophic thoughts are the big thing, and we've touched on these a little bit in some of the previous sessions that I've run. And basically the catastrophic thoughts are often really sort of problematic for patients. They think that their tendon is going to rupture, it's going to snap, it's actually going to lead to them having this problem for the rest of their lives, and they're never ever going to get better. And it's important we really understand what the patient believes about their condition, and we give them appropriate sort of understanding of the condition and appropriate expectations. Now, sometimes for somebody who is very down on what's going on, we might actually need to be a little bit over optimistic with outcomes. I think that can sometimes be justifiable in order to try and bring them out of it. And then at a later date, we will try and morph that understanding to help them sort of comprehend exactly what time periods we're talking about. But realistically, the timescale minimum we should be talking about with patients is normally 12 weeks. Okay, that seems to be pretty much what we can get for most patients for a good outcome. Equally, if they've got pain behaviours, we need to be aware of that. And this can sometimes come back to the other two entities as well. But it's where the patient is really sort of limping when it may be inappropriate to be limping, or they're actually overly exaggerating the response that they have in terms of the symptoms. And this is normally done at a subconscious level. This isn't a conscious sort of thought process with these patients. But sometimes making them aware of that can be very, very useful. And if there are poor behaviours, it's often useful to videotape the patient on their phone. Particularly if you're working in the NHS in the UK, we're not allowed to video patients on our own phone for GDPR reasons. So video on their phone to show them what they're looking like as they move and do things. That can be very good. Now, the key components about what the patient understands is, as we've already mentioned, the fear of sort of snapping their tendon. But it's also this whole other side of the coin where a patient may be sort of considering that I was feeling great, I want to crack on and do more, I'm going to go out for a much longer run, and then they wonder why that sort of breaks them down and flares them up again, because they haven't prepared to do that. And often what we'll get over here is sort of a bit of nice weather, and the patient will say, well, I had planned to do 3-mile run and I've inadvertently gone out and done 8 miles. And it's a bit like, well, how'd you inadvertently do an extra 5 miles for one thing? But equally, that surely explains your flare-up you've had as a consequence. And sometimes patients don't always sort of see that side of it. They need that sort of understanding and analysis from a third party like ourselves, so they can really get to grips with those particular entities. I do also think it's important to sort of tease out whether a patient thinks that their problem is an inflammatory disorder or not, because if they do, it tends to influence behaviour. But we shouldn't make any assumptions about that behaviour. We should ask the patients further. So if the patient thinks they have an inflamed tendinitis, then my sort of response would be, so what should you do in order to get better? And their sort of comment back would normally be, actually, I need to rest this until it feels better. Then I can go back to running. And that just perpetuates these boom-bust cycles that we've mentioned before, where the patients feel good, they do a lot, flare up, feel bad, do very, very little, starts to feel better, obviously, and then they can go back to doing a lot more. So it's this sort of perpetual cycle that they often go through. And we did mention that they may have one of these spirals where they just worsen and worsen, which is also a possibility as well. And then we'll have people who just say, well, of course, I'm never going to be able to run again. I accept that. And that also is not true. That's a sort of catastrophic thought. It's just not as severe as I'm going to snap my tendon. So we need to sort of say, well, we can run. It's going to be a slow program that you need to undertake, but there's no reason why we shouldn't be able to return the vast majority of our patients to normal physical activity, whether that's work, whether it's just going out for recreational walking and exercise, or whether it's actually more vigorous forms of exercise like competitive sports. Now, the key program that we've mentioned previously about successful rehab is we're trying to tick off a whole variety of aspects. We are trying to modify load. Now, sometimes that can be a challenge to do. Okay. Now, if we don't change these factors, we often don't get a very good outcome. So modification of the load is absolutely critical. And if we have a patient who has increased body mass index, we may find it difficult to modify the load through the tendon if they are habitually very inactive. Now, one of the components that I found quite useful for some of these patients in the past is to look at actually how they stand, and the majority of these patients will have very large calves because they're putting quite substantial stress through their Achilles and calf sort of region when they're stood, or maybe standing with the knee in a valgus if we're talking about GTPS, a gluteal tendinopathy. And what we want to do is take the stress off by altering their biomechanics of their stance. So for Achilles problems, what we're often doing is get them to bring the weight back onto their heel. So we'll go through an exercise where we might get them to go on the toes, back onto the heels, move the feet so the weight goes laterally versus medially, and actually then get them to sort of try and place more weight on the heel itself. And that will reduce the stress through the Achilles and the calf muscles. And in the case of an Achilles problem, we'll often make them feel better. If it's GCPS type disorders, then we should equally be looking at modifications to their stance position if they tend to stand and hang on to one hip, or how they're lying down at night and things. So they're all aspects we need to consider. But the biggest thing that comes out time and time again for me is that lack of improvement in normal muscle function, or the muscle tendon unit, I should say, as a whole. We're not historically, as physiotherapists, as sports physicians, as S&C sorts of coaches, we've not been historically very good at returning people to normal musculotendon function for a given tendon. We tend to look at resolutions for pain. And what we see in the majority of patients is they'll go on to have relapsing, remitting episodes of tendon pain. Now, I think in my mind at this moment in time that's largely because of a lack of insufficient recovery. We haven't done as much as we could to improve the muscle tendon unit function, to shock absorb and protect the tendon, and we haven't done anything to really change the tendon structure in the long term. Okay, but these all come under that sort of bigger remit of changing the person's thought process and changing their worry and what's going on, because that ultimately influences their desire and ability to actually engage in their rehabilitation as an active person within the process. So we really do need to sort of bring that back into it again. And you'll notice I've got diet and sleep as sort of blue, sort of a different colour on here, just from the bullet points. There's a suggestion that sort of protein intake, and it's something I've talked about in the past, will probably help tendon recovery. It's essentially the building block for tendon, and so if we're giving the body extra protein, we may start to improve the collagen content more speedily than we might do otherwise. We know that a lack of protein will cause sarcopenia in older patients. And just simply by ingesting more protein, we can actually reduce those effects and improve muscle quality. Well, tendon at the end of the day is just part of your muscle. Surely it will undergo similar changes. But at this moment in time, other than the study from Keith Barr's lab looking at gelatin, there is no actual studies that have been done on tendon remodeling with sort of protein ingestion. There's quite a few on carbs, but carbs aren't really the building blocks. So we need to be looking at this, particularly for injured tendons. Now, I don't really care what happens for a healthy person, because we know from a lot of other scientific literature that when you've got a disorder, it's often very different with how the body responds to a stimulus. So we need to be looking at this in injured, active sort of patients. Equally, we have to consider our rest periods as well during recovery, and this is one of those aspects where patients just often end up sort of, let's say, an active runner. We get them returning 3 days a week to running, and that they're starting to get PBs at whatever sort of race distance that they like to do. And what we'll find with these people is they then go, oh great, I'm essentially better, I can start to ramp it up a bit more, because if I'm training more, I'm obviously going to get a better time. And what they're failing to really comprehend is the recovery was actually making them sort of perform better. And by training harder, they are overtraining and then trying to compete when they've not had sufficient recovery periods, and that just exposes them to more risk of injury. And we know in runners particularly that more than 5 days running per week is associated with a large increase in injury risk. So it's one of those things we should sort of make our patients aware of during recovery, so they can comprehend how that might interfere with them, and just throwing it back on them so they make the decision rather than us necessarily telling them. That's very, very useful. And the time period is also obviously there. Like we said, looking at a 12-week marker, I think from the get-go is a good sort of figure to start to introduce. We'll probably find that we can get quite good benefit by 6 weeks, but it's really this 12-week time period where people start to notice larger changes. Now, the reason that we might be seeing some of this failure to respond to treatment is because actually what patients are telling us that they've been doing when we did our epidemiology work is stretching or massage or even ultrasound on there. So that isn't any of those things that we know, we think, or currently sort of base our rehabilitation on. And the previous slide is actually sort of an amalgamation of what all the tendon experts are saying. We all look at it and say that these are the criteria that we should be aiming to change. And if we can do so, we seem to get good outcomes. But our patients are telling us this is the treatment that they've had. Now, that's a problem for me. Stretching particularly is a problem, particularly when it comes to the Achilles tendon, because we know with people who have tendinopathy in the Achilles, their tendon is too flexible. It is more pliable. A healthy Achilles is stiffer. So we want to make it stiffer. We don't want to do stretching, and we know by doing muscle tendon unit stretching, certainly in active muscles where the muscle hasn't fully switched off, you will elongate the tendon tissue. So it doesn't make sense that we want to do that. And if the argument is the person has a reduction in the muscle tendon unit length as measured by sort of toe to wall, heel to wall tests, then maybe what we should look at trying to change instead is actually doing sort of loading at end of range, something like concentric or eccentric loading in a very dorsiflex position to restore the length with strength. Now that's probably the best thing we can do. And interestingly, the strongest position for the calf muscles is when the ankle is most dorsiflexed. Not in the mid-range position that many people talk to us about. It's in a full dorsiflex position. And that probably identifies where we need to be working, because that's when the most load goes through the tissue. And that's when most people find that they're most symptomatic. One thing I should point out, whilst the Achilles tendon gets less stiff, patellar tendons actually get more stiff when you have tendinopathy. Now, there may then be an argument that maybe stretching might be useful for patellar tendons. So it's something I think we should consider. And we're not clear on what happens to all the other tendons that we say tendinopathy in. The other bit then where we can go wrong during our management of patients is our differential diagnosis. We've gone through our diagnosis from the previous session where we looked at all the other disorders that could cause the posterior heel pain, and we determined that it's an Achilles tendinopathy. But within that tendinopathy umbrella, we have all of these disorders. And what we tend to find is that people aren't discriminating between these disorders. They're trying to treat them all as the same entity. And I don't think we can say they're the same entity. My current experience is certainly with these three elements. They do not seem to respond very well to loading at all. They will often worsen during our load interventions. In my study data where we've actually looked at rehabilitating these with normal eccentrics in the past, people who had a sudden onset of pain, which is probably what this group would have as a whole, seem to worsen or not respond in the same sort of speed and with the same benefit on a visa score as other groups will. Now, it's my expectation that when we look at gluteal tendinopathy, if we applied the same sort of level of diagnostic sort of methodologies, we'd actually start to identify subcategories within there. And we know that you can have tears of the sort of essentially the rotator cuff of the hip, and that's how some people will refer to it. We know there can be torn zones, and it may be that is important in considering how the response goes. It may be that having bursal changes are different to not having bursal changes versus having a bony reaction to not having a bony reaction. So these are bits I think we should really be considering. Should we treat them all the same, and would they respond all the same? We need more data, but in terms of practical applications to your clinic tomorrow, my suggestion is you ensure that your analysis pulls out these and you start to audit your own data to see how you find it. And if you're not finding the same responses, then I think we can start to say you probably need to change your interventions. Another aspect, we know there are muscle weaknesses that occur when you have tendinopathy. And what we tend to see with rehab is we see improvements with strength, but sometimes those improvements do not produce a full recovery in the muscle tendon unit function, whether that's looking at sort of the strength of the muscle here as measured by torque, whether it's looking at your endurance of the calf muscles here. And what we want to see is people who are healthy will normally fall into this category, the greens up there, whereas most of our patients, when we look at injured cohorts, are down here. And all we have on this particular chart is concentric strength up this axis and eccentric strength along this axis. And essentially, if you are injured, you're weaker. Now, we don't know whether this is the case pre-injury or not at this moment in time, but it would seem sensible that people who are stronger can function better. And we know that's the case when it comes to certainly elderly patients, and we're looking at activities of daily living. So we should be trying to improve those aspects. Now, equally, after 12 weeks of rehabilitation, what we see is we've moved people from the blue sort of concentric strength here to the red concentric strength. That's 12 weeks of eccentric rehabilitation, with the green data being healthy controls. Now, in this particular study, there's 24 people went through the full rehabilitation. We hadn't rehabilitated them above a known prospective risk factor, which was 50 Newton meters cut off for torque in that position. The mean for the group after rehab was actually only 49 Newton meters. So some had gone above it, but some were still below. Now, it's my conjecture at this point that that's probably why we see relapses as we go on during rehabilitation. Now, unfortunately, at this moment in time as well, we do not have data for appropriate torque and power for other muscle groups at this point. And that's something I think we probably need to be looking at. A lot of treatment can be spent on low-value interventions. Those low-value interventions can be ice therapies, used regularly, particularly if we're dealing with sporting people. And the problem with using ice frequently after any training activity is, yes, it will help pain. It will make the person feel more comfortable, but it will also blunt the chemical messaging ability of the cells, which would have stimulated change and adaptation in the tissue. Now, my suspicion, and again, we don't have robust data to show this, but my suspicion is this will lead to worse outcomes. So it's something that we currently recommend patients would ease themselves off and avoid, unless they have an acute flare, in which case they could use ice. And the same sort of theory applies to NSAIDs as well. So non-steroidal anti-inflammatory drugs like ibuprofen and similar sort of medications. These medications stop the low-grade inflammatory chemical messages which are released when we exercise, and that will allow muscles to adapt and tendons to adapt. Without these messages, the adaptation is poorer, or with a reduced amount. We can never abolish it. And both NSAIDs and ice, as I said, have been shown to reduce the muscle adaptation after loading. As we've said already, tendon is just part of your muscle. It will respond in the same way. So they're low value and something to be considered and avoided, except in the case of flares. Then when it comes to palpation and actually doing sort of things like friction massage to the tendons, or maybe even arguably specific soft tissue mobilizations, a la Glenn Hunter, if you've come across his work, it's sometimes useful for pain reduction in people. They'll report good benefit, but often we'll talk about this being like scratching a mosquito bite. It feels lovely that first time you scratch the itchy bite, but you're constantly going back and itching it, and before you know it, your mosquito bite's now a big welt that's huge, and actually sometimes you end up with even more problems like infections. But essentially it becomes more reactive and gets more irritated because you're constantly touching it. Now the same happens for tendons. I've seen patients who've constantly started to do these type of self-massages and ended up having to do it every few hours within the day just to get through a day. And these people sometimes need to go cold turkey and stop touching it. And that in itself will help desensitize the tissue, because their tendon in that instance has become hypersensitive because of the constant irritation. And we need to take that away. Now, irritation can also come about through doing other things like sticking needles into it. And we don't have epi, which is sticking a needle in and running sort of essentially heating the tissue up, which seems to be quite common in Spain. We don't have epi in the UK, but where I've come across it with elite sort of footballers is that this just seems to perpetually irritate the tissue and constantly drive an irritation within the tendon. Now, with tendinopathy, as we talked about in the first session on etiology, the tendon is overly active. The metabolic rate is huge. We want to calm the tendon down. So irritating it, sticking things into it will not calm it down. The only way we know of really calming the tendon cells down is to put controlled load through them and control the load. So it's not too much, not too little, but we stress them to stimulate cell activity. We just don't overstress. And then another common failure that we have within interventions is considering going through from these time periods. So injury in the top left to full recovery and return to play in the bottom right. What we'll often see is a push. The speed of that will be far too fast. And essentially what you're creating is a time bomb, that these active people will break down very quickly when they return to their activity or their sport. And it doesn't matter what sport or activity we're talking about. This could be walking to the shops. it needs an appropriate time period for some adaptations to take place. As far as we understand, those adaptations are neuromuscular, possibly with some tendon material property changes. If we use sort of the acute chronic workload ratio data, we know that as you increase the ratio, as you do more loading in a current week, you seem to have a higher risk for developing an injury. And this is something that we see in the vast majority of our patients who are active. We can use their Strava data or other sort of data management that they've got and actually look at what they were doing just prior to the onset of symptoms. And you'll normally see quite a big spike in training loads. And when we rehab, we should allow for these training loads to be gradually increased so it's not a spike again. But again, what we have come across with patients we've been involved with in certainly elite sport is this return to play is far too rapid for any tissue adaptation to occur, and the player breaks down, sometimes catastrophically going on to have surgery and a variety of other elements done. So let's consider appropriate timescales. Think about tissue adaptation. I normally talk to patients as this being 10 to 12 weeks for microscopic alterations. This will be some of the tendon material property changes that we probably get with our rehab. Neuromuscular adaptations are between 6 to 10 to 12 weeks plus. So we want to see these adaptations occur. If we can get a person back faster than that, I have to challenge whether that's feasible for a normal tendinopathy. It's certainly not something we commonly see. Now, the key points to take away from sort of this session are we're trying to change the relevant risk factors that led to the problem in the first place. So we've got to go back to that understanding of the etiology and why this person got that condition. What can we change? Because a lot of them are non-modifiable. And let's try and change those and get the patient aware of them so they can control it. We try and exclude or reduce the amount of low-benefit treatments that we utilise. That's particularly important. Focus on the big fish, the key thing. As far as the evidence substantiates at this minute in time, it is about isolated muscle tendon unit function. But we need to ensure that we integrate some other aspects, looking at the more complex movement strategies required for that particular activity or sport. So we can move on to more typical stretch, shorten cycle components like walking and running being elements of that, and plyometric training. We should always consider, if our patient isn't improving, a differential diagnosis. Did we get the right condition? If it is the right condition, is it the right component within those umbrellas that link to tendinopathy? Have we given it an appropriate timescale? Have we actually quantified what the deficits were and shown that these have improved if we're going there within that time? This has all, though, got to be done under the patient as a whole. And all of these entities, without considering the person, will not get a good outcome in my experience. We have to consider the person, and we have to get them to understand what's going on, what they need to do to be successful, and why they shouldn't be fearful of certain potential calamities happening to them. And also what they can do in the long term to help try and maintain good sort of health for themselves so they don't have a relapse of whichever tendinopathy it was. So hopefully this gives you some key points to consider when you see patients who may have failed with somebody else or failed your own care. And I would encourage you all to complete some sort of reflection on your most recent tendon patients that haven't done as well as expected, to try and comprehend why that occurred. Which elements did you maybe miss, which weren't really bought into by the patient, and how can you then try and change those in the future as you go forwards? So, thanks again for listening, and I'll catch up with you all at some point in the future. Cheers.